So we're going to change things up a little bit now, start looking at some pictures that are not necessarily cardiac, but really touch on a significant aspect that underlies a lot of what we do with congenital heart disease, and that is really the underpinnings in genetic etiology. Same disclosures as yesterday. So congenital heart disease, as we all know, has a very strong relationship with aneuploidy syndromes, single gene mutations, as well as, if you're speaking about array, copy number variants or variants of uncertain significance. The extent of that association differs significantly by lesion. So some of them, such as typical D transposition, are very weakly associated with any underlying genetic etiology. Others are very strongly. The genetic basis is likely to become a bigger component to things as we get better at our testing. So when we looked at simple things like karyotype, there was a substantial amount of CHD that did not look like it was associated with gross abnormalities on fetal karyotype. But as our resolution increases, so microarray, next generation sequencing, and now as we're into exome and potentially genome sequencing, these genetic associations are starting to become a lot clearer. Specifically related to exomes, and obviously genome, which will include an exome, we're starting to see these emerge significantly. The RASopathies, which would be abnormalities within the Noonan spectrum, which we'll get to shortly, ciliopathies, and various types of heterotaxy. So some lesions, as I said, are more syndromic than others, and two of them that have very strong associations with underlying genetic etiologies are anything within the tetralogy spectrum as well as AV septal defects. So tetralogy absolutely can be isolated, but can be seen with trisomy 21. This is, I think, a typical fetal echo board question when they ask you for the type of cardiac lesion that's most strongly associated with trisomy 21. Everybody answers AVSD, but it's actually tetralogy AVSD, which has a stronger association. Trisomy 18, DeGeorge, Alagille, multiple other syndromic associations. Similar to AV septal defect, absolutely can be isolated, but a good rule of thumb, if you see one on an ultrasound, your immediate risk of Down syndrome is about 50%. Trisomy 21, various other syndromes, etc. So as a good point of reference, and I'm going to draw your attention to this article in 2018 by Pierpont. It's really a good comprehensive article on the genetic underpinnings of CHD in general. But if we break it down based on what was known in 2018, genetic environmental overall probably only contribute about a third to slightly less than that of etiology. We're left with single gene disorders, gross chromosome abnormalities or aneuploidy, meaning ones that you're going to pick up on a karyotype, pathogenic variants as part of a CHD syndrome, isolated, and then a whole host of other things that account for less than 10%. We still have some that remain unexplained despite extensive testing. One of my repeat patients, I think I've actually seen her for 3 pregnancies, has a child who is very strongly within a RASopathy spectrum by appearance. But even as far as genome testing, has absolutely no abnormality that we can delineate. Chromosomal abnormalities and congenital heart disease also differ, as we mentioned, by type. And when we talk about chromosomal, we're talking about significant deletions, duplications, or things that don't require high-resolution testing to elucidate. And that, as I said, differs depending on lesions. The 2 forms of transposition, congenitally corrected and DTGA, have a very low incidence with aneuploidy. You can argue that if it is there, it may just be random, as in true, and unrelated. But then we get to this spectrum, as I mentioned earlier, tetralogy, double outlet, so lots of conotruncal disease as well as AV septal defects that very strongly underlie genetic heart disease. So what does this mean for testing? Whether you are likely to pick up an association obviously depends on what you choose as testing. And we have gone from, I have another talk where next to the word karyotype, I have a Fred Flintstone car, not to imply anything other than that's what our knowledge has been really basically since the Stone Ages of genetic testing. Right here, we're somewhere into George Jetson's flying saucer. So depending on what you pick, you are likely or unlikely to pick up the abnormalities. Now, these are not absolutely intuitive, right? Like, I think a lot of people are under the impression that if you have a normal microarray, that's as good as it gets. And that's so, only because I'm like firmly believe in analogies to make things make sense to people. If you think about your genome as a set of Harry Potter books, right? 6 or 7 or however many books she wrote. A karyotype is going to tell you if you have all of the books in the series and if they are complete. A microarray will tell you if all the words are present in all the books of your series. But an exome or genome will tell you if any of the words are spelled wrong. And that's important because nucleotide substitutions are what change protein, are what change genes, are what change things to Noonan and other RSopathies. So a microarray is obviously a huge step ahead of just a standard karyotype, but it is not going to give you single nucleotide substitutions or single gene mutations. We also tend to think of these as whether they're targeted, meaning I kind of know what I'm going after. Let me test my hypothesis, for example, with a fish that's targeted at picking up a 22q deletion. Or genomic, meaning let me cast a wide net and see what comes back. And these are, both of them have interchangeable features. Like a genomic test will also pick up your targeted concern, but you have to judiciously pick based on what you think you have, what you're likely to pick up. For example, if you have a baby with an AV septal defect that every other part of that ultrasound screams Down syndrome, you probably don't need to do exome sequencing. Your karyotype will be sufficient. So, based on your desire to pick up aneuploidies rearrangements, copy number variants, or single nucleotide substitutions, insertions, and deletions, you need to pick your test accurately. As I said, obviously, there's some overlap between the two. Other technologies, I've left this here sort of deliberately really small because I'm kind of fatigued about explaining the limitations of cell-free fetal DNA to people, like really tired. So again, go back to our first test that was available, right? Amniocentesis, I think, came about in the 60s, if not early 70s. What if we start adding these types of technologies to our testing? What's our incremental yield of picking up congenital cardiac defects with normal NIPT testing? And here's a good paper from the Gray Journal in 2021. If we add microarray to ostensibly a normal NIPT, what do we pick up additionally? And you can see that the biggest gains in knowledge are with very similarly the things that are highly genetic in etiology. So AV canals, hypoplast, ventricular asymmetry, meaning you're picking up some of those left-sided obstructive lesions. A lot of the multiple cardiac and extracardiac, non-isolated, and septal defects. So not to go through these in graphic detail, but the idea being what you think is normal may not be normal the more you subject it to rigorous and detailed high-resolution testing. What about the results for an abnormal microarray in pregnancies with CHD following, again, theoretically normal NIPT? If you use a 3-chromosome NIPT, meaning 13, 18, and 21, in the control population, that's abnormal only about 1% of the time. Isolated CHD, you double to slightly triple your detection rate with that, and that's because it's going to pick up those trisomy 18s, trisomy 13s, really the more common ones. With non-isolated CHD, which again will heavily fall into an aneuploid population, you'll pick up probably 6 times the baseline incidence with 3 chromosome. As you start including more information, you can see that the non-isolated CHDs are consistently going to be picked up at a higher rate than the ones that are isolated or normal. So moral of the story is we've progressed here from 5 chromosome to adding a 22q, that should say 22q11, to genome-wide NIPS. The data on exome sequencing is just starting to come out. And I slapped this slide in just a couple minutes ago only because this is a paper that really started to look at the difference between aneuploidy pathogenic variant and single nucleotide variant, which again is you're only going to pick up on exome or genome sequencing. In this population in China of about 400 patients with congenital heart disease, 10% of those were due to aneuploidy. The overall incidence of a genetic finding was about a third. 13.5% due to a pathogenic copy number variant on array, but another full 8% were abnormal based on a single nucleotide variant, so something that you would only pick up on exome or genome. So as we incrementally increase the resolution of our testing, we're going to start to find that the genetic underpinnings of this are far stronger than we appreciated. So this is just going to be a tour of a bunch of pictures because they're fun and if they help anybody. We're going to go over chromosomal aneuploidy and copy number variant with CHD and focus on some of the more common syndromes that you're going to encounter in general practice. The trisomies, so the chromosomal aneuploidies, meaning extra or absent full chromosome, some of the more common syndromes, and then talk just a little bit about the ciliopathies and other. So everybody staring at this face, I'm sure, knows what this baby has, right? It's the baby with trisomy 21. So Down syndrome trisomy 21 is the most common chromosomal abnormality associated with CHD. Why is that? Because it's the most common chromosomal trisomy that we see. Most Down syndrome is due to trisomy 21, but be forewarned. There is this tendency for patients and practitioners to intertwine these two findings, right? Oh, my son has Down syndrome. Oh, he has trisomy 21. Maybe. 98% chance he has trisomy 21, but never forget that there's going to be a 1 to 2% of these patients that are due to translocations that are unbalanced. And these are familial and have a high incidence of recurrence and make it imperative that you don't counsel people that this is sporadic till you've excluded the familial variants. For this population, congenital heart disease causes 13% of childhood and 23% of adult deaths, and the smattering of what we see commonly, ASD, VSD, obviously these two are part of this spectrum. PDA is not a fetal diagnosis, but since this is a postnatal paper, I've left this up there. Tetralogy of Fallot, TET-AVSD, being a lesion that has about a 70% likelihood of being Down syndrome if you encounter it, and then a smattering of others. So first trimester markers, as just a kind of political comment aside, I'm saddened to see this scan really go by the wayside for a lot of people now that NIPT testing is believed to replace this. NIPT testing is really, really, really good for the very few things it tests for, but the nuchal translucency itself is a marker for a lot of other badness, including congenital heart disease. And, you know, I feel like in my own personal practice, we've gone backwards in some ways that now I'm seeing anencephalics at 18 and 20 weeks that would never have gotten that far if but for the NT scan. So anyway, now I'll shut up. Nuchal translucency screening was a potent predictor, not just for aneuploidy itself, but also for an increased risk of CHD. Here is a fetus again with an absent nasal bone. The nice part about these markers, I mean, that's the good part about NIPT, right? A low risk NIPT means we really don't have to stress about an absent nasal bone and kind of ascribe that to, well, it's more common in the African American population, the Asian population. So some of these findings are really well addressed by NIPT. Other first trimester markers, and I use these primarily as screening for congenital heart disease because I'm not looking for risk revision for trisomy 21 anymore, but reversal of the A wave and the ductus venosus, which has a little bit more of a prediction for right-sided obstructive lesions, so pulmonary stenosis, PAIVS, that type of thing. Tricuspid regurgitation, absent nasal bone, you can see here. And really, I put this up just to highlight the fact that there is such a thing as picking up congenital heart disease in the first trimester. This is a transabdominal scan, so I can't even really claim high resolution transvaginal, but here you can see the common AV valve and the echogenic intracardiac focus. So not a huge guess as to what this baby probably has. We've discussed the linear insertion of the AV valves before, again, with the floating little white dot in the septum, which represents your septum primum defect. Anything within the AV septal defect spectrum is more common in fetuses with Down syndrome. Other features to look for: thickened nuchal fold. Jugular lymphatic cysts are seen more commonly at early gestational ages, but if you see this on either side of the neck, here you can see it axially, here longitudinally, put color flow on just to convince yourself that it's really not a vascular abnormality. I have a thing about 3D, as you might imagine, profiles, and one of the things that, maybe it's published, certainly not by me because I haven't written about it, but I'm always impressed by kind of the bagginess of the lower lip of babies with Down syndrome. And I have a couple images that show that pretty dramatically. And I think that's really just a reflection of the gross hypotonia that you see in these babies. But typically, flattened profile, flattened midface, increased prenasal edema. Here we have a little bit of macroglossia with tongue protrusion, but look at the bottom lip in all of these babies. And I think that's just in utero hypotonia. It's not one that I can tell you people focus on in terms of written literature, but it's just a recurring theme in these babies that I see. And here again, we have this flattened midface, thickened prenasal thickness. Liver enlargement is one that is definitely published into the third trimester in fetuses, thought to represent extramedullary hematopoiesis due to myelosuppression or transient leukemoid reaction in these babies. I will tell you increasingly, if you train your eyes to look at this, you're going to see it more into the second and potentially first trimester. Enlarged livers, and actually this is not a great example of this, but enlarged livers often look a little bit hypoechoic or a little bit waterlogged. And if it strikes you, it's probably a good idea to measure it and compare it against some norms for gestational age. Clinodactyly, I put this up there just for fun, but this is usually where the audience all holds their hand out and realize that probably a third of us have clinodactyly, so not particularly helpful as far as true markers. Hypoplastic middle fifth phalanx is definitely more common in fetuses with Down syndrome. You can see here we have nice ossification for index finger, but not over here for the pinky. Aberrant right subclavian artery, I think, kind of gets back to where we are in this meeting, which is cardiology. It's one of my favorite things to look for because it's one that sounds really hard, but it's actually really easy. If you can look at a 3-vessel view and train your eyes just to come a little bit above that, once you've seen it, you'll get it. There's not a huge learning curve for aberrant right subclavian arteries, but it's very helpful for kind of likelihood risk revision for Down syndrome as well as 22q. The dilemma this causes me in practice, it's not really a dilemma, but 22q is not frequently added onto people's NIPTs early in pregnancy. So when they have them done in their doctor's office, let's say at 10 or 11 weeks, they may come with a low-risk NIPT for trisomy 21, which is a really easy discussion vis-a-vis an aberrant right subclavian. But then we have to have the 22q deletion, which oftentimes they choose to repeat the NIPT, which is a little bit financially problematic. Anyway, this is present in 1% of normal fetuses, much more commonly in babies with trisomy 21, depending on the study. Management when isolated is controversial. For me, it's an indication to do a really good fetal echo, look for other risk factors related to 22q, and re-offer the non-invasive screening. But with other abnormalities, obviously considering diagnostic testing. So here's a 3-vessel view. So here's left side of the fetus, right side. Here we have our transverse aortic arch, MPA ductal arch, and this little sonolucency right here is the trachea. You can see that this vessel comes off the distal aortic arch and travels rightward to the fetal shoulder. So that's just an example of an aberrant right. You absolutely can pick this up at 12 weeks. You can pick it up at any gestational age. Moving on quickly to Turner syndrome, common abnormalities, cystic hygroma, right? That's your 12-week presentation of Turner syndrome, is the baby with the large septated hygroma. That is not necessarily restricted to the fetal neck. Oftentimes you'll see marked nuchal and facial edema. it can also translate to sort of that full body spacesuit baby, you know, the baby that looks like the Michelin Man, edematous all over. Effusions with high drops, posterior low set ears, rotated dorsal pedal edema, and the left-sided obstructions, which are definitely amenable to detection. So I've had about, 6 or so of these in my life, but first trimester, this is an 8-week fetus with bilateral pleural effusions. All 6 that I have historically are confirmed Turner syndrome. So I put that up there just to say if you have one of these babies, number 1, high likelihood of Turner's. Number 2, very high likelihood by the time you get them back at 12 weeks, there's a demise. This one was extra fun. Monochorionic triamniotic triplets, all with effusions, all clearly with Turner syndrome by chorionicity. Here's your more classic appearance of Turner's in the mid-trimester. So this is about 16 weeks, large posterior septated cystic hygroma. Again, this may translate to full body edema. So here you can see we have a shot kind of through kidneys, upper abdomen. We have diffuse subcutaneous edema with the skin standing off. And I put this up only to remind everybody, phalloceal is absolutely a feature of Noonan syndrome. It just tends to get forgotten on the list. So if you see this, remember again, appropriate to think trisomy 18, Turner syndrome, also appropriate to think Turner syndrome. I'm gonna mentally confuse Noonan's and Turner's this whole talk. Left-sided obstructions. So if you can get past the shock factor of the edema and the cystic hygroma, concentrate on the heart because there's actually a lot of information there. Here you can see this baby again as one of these large spacesuit type babies. Already we have marked discrepancy in size of right ventricle and posterior left ventricle. This is slightly later in gestation. Again, full-on edema. Here we have an effusion already. Very, very small left-sided progressive obstruction. And here finally later on in gestation, one of the bigger surprises with this one is that this baby was actually still surviving quite this long. But here we have sort of the evolution to the typical hypoplastic left heart syndrome appearance, massive edema, effusions throughout. But this doesn't have to be that striking, right? What do you think about when you remember genetics in medical school, Turner syndrome, coarctation, right? So remember these later on in gestation features that can tip you off. The smaller side left ventricle, the hypertrophic muscle-bound right ventricle. So always be aware to be looking for the features of left-sided obstruction. Bicuspid aortic valve is another favorite of mine. I have a great rendered view of this, but I didn't want to go too much into 3D because I know that's a separate talk. Vactral association is another common one, and I struggle with / hate this diagnosis because it's really one of exclusion. And despite extensive testing, even with exome and sequencing, you often come up with nothing, right? You're left with, baby has a hemivertebrae, baby has a cardiac defect, baby has a renal malformation, and I don't have anything else that points me in the right direction, so it must be vactral. It's just not that rewarding for parents that you are guessing because we don't have anything firm. Conversely, the good side of vactral is, in general, these kids are normal intellectually, and it's the sum total of the abnormalities, the extent to which those can be repaired, that they will do well, but it doesn't necessarily have to have a bigger significance. So there's really no specific pathognomonic, consistently abnormal genetic finding noted. There's sporadic cases that show some gene abnormalities, but not one you can really ever hang your hat on. And a lot of these cases are fundamentally true by syndromic association, yet are negative by genetic testing. That said, genetic testing is still important, right? There's a lot of things that can look like vactral. A big one being trisomy 18. So, don't get overconfident in making this association because there are meaningful results that can come out on your testing. This is a first trimester fetus. Everybody wants to call this a bladder, but you're going to have to trust me when I tell you the bladder is actually separate. This is a transient but first trimester manifestation of anorectal atresia. And this is actually typically right-sided, believe it or not, but you can see that this is pointing right towards the perineum, which is where the low anal atresia occurred. This disappears by the second trimester. So it's just an interesting first trimester finding. Radial ray abnormalities, very common with Vactral. These can range from complete transverse amputations, radial ray defects, absent thumb, etc. Here's just a whole host of other ones from years and years of collecting them. Here's a baby missing the left hand with just a little bit of a nub in here. Spinal malformations, sometimes super obvious. Here we have obviously a major scoliosis to the upper thoracic spine. Sometimes it's a little quirkier, right? Like notice this little divot right here, that's your hemivertebrae. And these are the kind of things that I will tell you are trickier to see in 2D because you're always second guessing yourself, like, is it, isn't it? So if I can make any plea for rendering vertebral bodies, it's going to be for hemivertebrae. Sometimes they're just disorganized segmental abnormalities, as you can see here. The nice pairing kind of stops here in the upper lumbar region, and then we have these abnormal views. Again, here's another one, spinal segmentation abnormality in the lumbar spine. Kidneys are fun. Here, as you can see, I'm kind of panning back and forth between an upper normal kidney here and lower. And this is a baby with cross-fused ectopia, which actually tends to be more right-sided than left. Here's a baby with a horseshoe kidney, which I think you can see if I highlight it in pink. Asymmetric, notably hydrocephalus, is part of the H in the Vactral H association. So here you have a baby with decidedly more left-sided ventriculomegaly than right. Noonan syndrome is, again, part of what I mentioned, the RASopathy spectrum. So we used to consider Noonan's as a discrete syndrome. There's now a tremendous amount of overlap with all of those RASopathy spectrums, which I'll give you a good reference chart for. This is technically speaking a dominant disorder, although most moms or dads are not affected. It's usually sporadic in the fetus, with an incidence of 1 in 1,000 to 2,500. In contrast to Turner syndrome, which with very rare exceptions is female, this has an equivalent predisposition in genders and largely relates to a PTPN mutation gene on chromosome 12q. But there's a whole host of other ones that are within that RASopathy spectrum now put into RASopathy panels by genetic testing companies. And as I said, this is a disorder of the RAS mitogen activated protein kinase pathway, collectively referred to as RASopathies. And there's a whole host of kind of typical features that overlap many of those phenotypes. So dysmorphic facies, short stature, web neck, etc. I'll leave this for you to read. This is actually from rasopathies.net or net.org. I love this chart, but shows you Noonan's, cardiofacial, Costello, and then a host of other ones. But you can see that there's a lot of really, really typical abnormalities that are common to all these disorders, and it's only the genetic testing that helps you separate Costello from Noonan's. Neurofibromatosis, interestingly, is now considered part of the RASopathy spectrum, as well as Legius. So this, if you go to this website, you'll get a lot of additional information on this if you want to. So first thing to remember with Noonan syndrome is the cardiac abnormalities can be progressive. My most recent Noonan's baby went from fairly normal looking heart to such hypertrophic cardiomyopathy that there were almost no chambers that could fill, probably within 2.5 to 3 weeks. And it was really shocking. In contrast to, really just as a quick mnemonic, Turner's, which are mostly left-sided obstructions, with Noonan's and RASopathies, you want to think a little bit more right-sided, but not 100% so. These tend to be dysplastic pulmonary stenoses, and again, hypertrophic cardiomyopathy that can be very progressive very quickly. Other abnormalities that kind of cross over to other syndromes, but cystic hygroma, skeletal, umbilical and ductus venosus abnormalities, which have really been addressed wonderfully in this conference, renal, macrocephaly. Here's another patient of mine, small, low-set ears posteriorly. You can see how large the head is. Ears look very much like her prenatal picture. So increased nuchal fold. This is a baby who has such massive hygromas on the nuchal region that these little rocks in the center are like the concentrated debris within the lymphatic system that has kind of sat there over time. Persistent right umbilical vein, which was mentioned in Alfred's talk, but again, umbilical and ductus venosus abnormalities highly represented within the Noonan spectrum. And again, this picture should look familiar to people. Here's a baby with evolving cardiomyopathy as a consequence of Noonan syndrome. You can see that the left side or the right side of the heart is demonstrably smaller. I think we have just one more to go through, so I'm going to whip through it quickly, which is Holt-Oram syndrome, often referred to as the hand-heart syndrome or atriodigital dysplasia. The most common and conserved features are congenital heart disease and radial ray defects, but the penetrance of the upper limb abnormalities is complete, but maybe absolutely subtle. And I have a family I've seen 2 children of who are fairly devastatingly affected with Holt-Oram syndrome. Dad had tetralogy, but nobody ever thought more of it, that it could potentially be syndromic. No visible hand abnormalities or limitations, but if you x-ray his wrists, he does have a subtle carpal abnormality. And he's mutation proven, by the way. So to the extent that fetuses don't really show us their carpal bones, this can be tough if you're going to do it just phenotypically alone. But some of the things to look for, any range of upper extremity defect, typically the left side, triphalangeal thumb, etc. Importantly, the degree of limb deficit does not correlate with the severity or complexity of CHD, and the mutation typically is in the TBX5 gene. So we're just going to go through these quickly. Here's my little triphalangeal thumb. And we're going to finish it up with 22q syndrome, just because this has been mentioned quite a bit. This is the most common microdeletion syndrome. And actually, at very young maternal ages, this is astoundingly more common than Down syndrome. So that'll be my little plea for considering putting 22q in your NIPT. It's often used interchangeably with DeGeorge velocardiofacial and has to do with a deletion on the 22q portion of the chromosome. 90% of cases have a fairly typical 3 megabase pair deletion, but some of them are inherited in smaller regions. So 20% of them are generally through maternal lineage inherited, but there's a good chunk of them that are de novo. There's actually a good chunk of them that are also the affected parent that never realized they were affected till they have a very affected child, and then we start to look backwards and realize that parent had learning disabilities and a soft palate cleft and maybe some other abnormalities. So there's a contiguous gene deletion syndrome for 22q, typically within the A to D region of the chromosome. In 87% of individuals, it's going to encompass this segment, but there's a smattering of others that have smaller or larger deletions, which may result in atypical phenotypes. And the A to D regions are constituted by 4 discrete blocks of low copy repeats. The characteristic deletion, which is this A to D, is at least 10 times more common than any of the other subtypes, but you have to remember that the genes are distributed differently across these A to D regions. So what do we see phenotypically in children? This is from Donna McGinn's study in the CHOP population. There's a lot of this that we can posteriorly extrapolate to look at a fetus, but the prenatal findings are definitely a little bit different. Cardiac abnormalities are high. Obviously, interrupted aortic arch is the most significant one, but some of them are nonspecific. Polyhydramnios, diaphragmatic hernia. You don't always think of those things related to 22q. The other one that people tend not to think about is club feet. So I'm going to remind you that club feet is actually fairly consistent in reports. The ones that we can look for by ultrasound easily, cardiac and cleft palate, but remember what's not included in this list is nobody's talking about the thymus gland. So again, the estimated frequency of a 22q deletion depends on the type of heart defect. Conotruncal interrupted arches, aortic outflow abnormalities are going to be highly correlated, not so much so other things like AVSDs or isolated VSDs, but the incidence is never zero. Soft palate cleft can be tricky to pick up in a fetus because by definition, those babies have intact lips, hard palate, alveolar ridge. And because it's not a flat structure, it's a dome-shaped structure surrounded by bone that creates artifact, it can be really hard to look at a soft palate discretely. There's a lot of volume-based imaging modalities you can use, but not only does that presume you have a really high ability to use 3D, 4D, it has some limits to acquisition. So I've kind of been on the bandwagon of telling people to look at the uvula for 15 years. But it's really easy. It's another one of those ones that sounds difficult and is astoundingly easy. The concept being that if you have a soft palate cleft, you either don't have a uvula or you have a bifid uvula. So if you can train yourself to look through the fetal oropharynx as it's swallowing or has some fluid in it, this is actually fairly easy to pick up. And here's this little doohickey of an uvula, and they call it the equal sign because the border of either side of the uvula looks a little bit like an equal sign. Here's a fetus with tetralogy who we're observing in real time for quite some time, does not have a uvula. And here's a baby with a bifid uvula, which was a tetralogy absent, tetralogy pulmonary atresia with MAPCAs. Thymus evaluation, again, I will whip through. In the third trimester, this is fairly easy to see directly because it's a little bit hypoechoic in front of the 3-vessel view. The dilemma comes more into the second trimester when that thymic mass is not really easily as visible. And what you're looking for is surrogate markers to show you that there's a mass of thymus there. The first one is to look at a simple ratio of how far back in the chest is the anterior border of the aorta as a surrogate for if the anterior border of the aorta is midway back in the chest, the reason it must be there is because there's a massive thymus in front of it, if that makes sense. So there's a thymic thoracic ratio, which includes measuring from the posterior border of the sternum to the anterior border of the aorta, and again to the anterior border of the vertebral body, looking at normals, congenital heart disease without 22q and with 22q. And the long and short of this measurement is that it tends to be much smaller in fetuses with 22q, reflecting the hypoplasia of the thymus gland, whereby the anterior border of the aorta comes more closer to the chest wall. So here's a normal baby with a ratio of 0.4. Here's a baby with tetralogy. You can see how little we have here in front of the outflow tracts with a ratio of 0.2. I know Alfred and Elena are using a slightly different version of this, which is a similar ratio, including the anterior border of the brachiocephalic vein, mostly on the premise that brachiocephalic vein anatomy is going to be more conserved and normal in the face of outflow tract abnormalities than the anterior border of the aorta, but the concept is similar. If the ratio is too small, the vessels are too close to the anterior chest wall, and that's probably because the thymus mass is absent. I'm going to skip through this to get to the fun case. Finally, one more marker which became important in the last case I'm going to talk about, which is looking at the dilated cavum septum pellucidum in fetuses with 22q. And this was kind of a posterior fetal life extrapolation from postnatal data that looked at the size of the cavum in children with a 22q deletion. So this is a really elegant paper looking at the width of the cavum at the level of the BPD as a ratio to the biparietal diameter itself. And in this population, you can see, number one, the cavum showed a linear correlation with BPD, meaning the larger your BPD got, the wider the cavum got, which is appropriate. But it is atypically wide in many children with 22q deletion. And you can see this scatter plot for normal. As BPD gets bigger, so does the cavum. But especially for the subcategory of fetuses with a BPD over 50 millimeters, 87% of them plot above the 95th percentile for gestational age. So finally, my last case, and I apologize for running over a little bit. This is a patient referred for outside choroid plexus cyst. No family history of any significance was related to us by her physician, except when you talk to her, you realize she has several older children with learning disabilities, ADHD, a brother with schizophrenia, a strong family history of congenital hearing loss. And in addition to an NIPT, we added the 22q microdeletion, received a result that said maternal deletion suspected based on a 22q. Maternal microarray was confirmatory, but notice what we have here. We have a central microdeletion of B to D, right? Not that full A to D deletion. Why is that important? Well, the A to D deletion, as we said, is the most common one, A to B second common, but look at what some of the smatterings of these genes code for and where they're located. This index patient we're talking about has a deletion in this area. But the genes for cardiac, conotruncal, neural crest all tend to fall within that A to B region that she does not have a deletion for, which probably accounts for why there isn't a highly represented history of CHD in her family. What lives in this area? Well, cerebral dysgenesis, short stature, facial dysmorphism. The other finding is the FISH probes we use tend to, at least until recently, really pick up this A region deletion. So you have to be very careful about what you're testing for. We looked back at her scans. Her first scan puts her here as far as CSP width, second over here. So based on that finding alone, we were fairly concerned that the fetus would be affected with the same deletion, which was exactly the case. So I'll leave you with a picture of Lake Louise, which is my favorite place on earth. Thank you, guys.